Hello everyone, David Wilson here from Dr. Stem Cells, and in today's video we are going to look at a paper which shows us the effects of bone marrow derived mesenchymal stem cells on chronic low back pain. There are a few things we should mention about this paper. As I'm sure you can see here, it is a 12-month follow-up, but it's an open label prospective control trial. That means that they planned it, it's looking forward, so that's a good thing. It's a control trial, so there's a control group versus a treatment group, but it's not randomized and it's not blinded. If it was blinded, if it's double blind, neither the doctor nor the patient know who's getting what. If it's single blinded, the patients don't know and the doctor does. And if it's not blinded, then both parties know what treatment is being given. And in this case, they knew because the control group did not receive the stem cells and the stem cell group did receive stem cells. So it was pretty clear to both parties who received what. So as you can see, they speak a little bit here at this top of this paper about regenerative medical interventions and how they're applied to assist in repair, to restore or replace damaged tissues. They also talk about the autologous use of autologous versus allogenic biologics, so taking stem cells from your own body versus taking from someone else. In this case, this study is looking at taking stem cells from your body, something I think is definitely very worthwhile and very positive. Again, they also mention here that multiple pain generators have been hypothesized to be responsible for severe spinal degeneration. This is very important, and this is something that actually I will link to one of Dr. Pont, Jeremy Pont, his chiropractic opinion videos where he talks about these treatments, because there is a very complex biomechanical structure around the spine, all this supporting apparati, as well as the bones, the joints, the discs, and how those all interact, including pressing on nerve roots, for example, among other issues. Now they talk here, it's a prospective open label non-randomized control trial, and the reason it's open label is because both parties know what's being given at the time of treatment. They want to see the effectiveness of autologous bone marrow mesenchymal stem cells in treatment of this type of pain and in people with severe lumbar spinal degeneration with involvement of multiple structures. Again, these are the worst patients in terms of patients who have most amount of pain, and this is something I think is a very good study design. It's just a pity that we couldn't do randomized double-blinded. However, must needs, and in this case, as we'll get down to, there are still very statistically significant results here. We can look at the methods. The treatment group received a one-time bone marrow concentrate injection into spinal structures, and they say here discs, facets, spinal nerves, sacroiliac joint, etc. Now we'll get a little bit more into the weeds of this a little bit later on. The conventional treatment they were offered as well meant that there was no real change in terms of the baseline treatment being offered to both groups, because the control group, as you can see here, also received conventional treatment with NSAIDs, over-the-counter drugs, structured exercise programs, physiotherapy, spinal injections, and opioids as required. Outcomes were assessed using different questionnaires. In particular, and of particular interest to me, is the Oswestry Disability Index. I have it here. Let me see, there we go. This is the Oswestry. And as you can see here, the Oswestry is a paper or an index which asks specific questions to try and judge or consider patient pain and problems. So we have pain intensity, personal care, lifting, walking, sitting, standing, sleeping, sex life, social life, traveling. And those last three definitely seem to mean as much, if not more, to patients nearly than some of the others, when we see that if someone has effects on their ability to travel, their ability to have intimate relations, or even just simply their ability to sleep and have a social life. Those kind of things can have a lot to say for quality of life, as opposed to the pain in direct numbers. So a pain score is not always the be-all and end-all. A lot of it, we want to see patients telling us how they react, how they act, and how they work in everyday life. And that's why these questionnaires are so useful. The results, also worth noting here actually before we go to results, we can say, also worth noting here before we go to results, they have these different questionnaires looked at, multiple outcomes were assessed, primary outcomes being minimal clinically important differences MCID in the Oswestry scores between groups and or 2-point reduction in pain scores. In the study group, total nucleated cells, colony-forming units, fibroblast, CD34 positive cell numbers, and platelets were also recorded. This is very interesting because in bone marrow especially, you're getting a mixture of stem cells with other types of stem cells as well as platelets. So actually a bone marrow aspirate is a bit like an activated mesenchymal stem cell from fatty tissue, where you've actually activated it with platelets before injection. So this is a very interesting number to be able to look at, and we'll look at those numbers a little bit later. Results. Also, I forgot to mention this earlier, You can download this full free manuscript at painphysicianjournal.com, and this whole journal article is open source, so anyone can look at it and consider these numbers. So please have a look at it yourself if you would like to, and you can see this is published about a year ago now, March, April 2022. Results: there was a significant improvement achieved in functional status measured by the Oswestry, pain relief measured by NRS11 and other parameters as measured by these other studies in the study group relative to the control group at all time periods. The results showed significant improvements at 12-month follow-up, where 67% of the patients in the study group had at least this so-called minimal clinical important difference using the Oswestry, when compared to only 8% in the control group. So that's a massive difference, 67%, 2/3 versus less than 1 in 10, 1 in 12 actually. Greater than 2-point pain reduction was seen in 74% of patients at 3 months, 66% at 6 months, and 56% at 12 months. But again, you can see how there's this difference, which isn't just pain related, it's also related to function in everyday life. Both MCID and pain relief of 2 points were significantly different compared to the control group. Opioid use decreased in the investigational group, whereas there was a slight increase in the control group. Age, gender, opioid use, and body mass index did not affect the outcomes of stem cells. Now, we could look at this in more detail. This is a really interesting paper. They've done a lot of good homework here, where they, for example, talk about lower back pain being seen as one of the most expensive, not the most expensive medical condition in the United States. They have an annual expenditure of $134.5 billion in 2016. This surpasses diabetes, ischemic heart disease, blood pressure, and other diseases, in fact. The reason for this is because they say that 50 to 80% of adults will experience lower back pain at some point in their life. So almost everyone will have it at some point for a while. And then they go down a little bit further. A global review of prevalence of lower back pain in the adult population has shown that its point prevalence is approximately 12%, so at any one time, about 1 in 8 people will have back pain. Healthcare costs have been overwhelming, with a major burden on the economy in the US, leading to implementation of various healthcare reform measures, regulations, and the imposition of guidelines, which have often been based on public policy priorities to reduce the costs. And actually, that's also interesting, because reducing the cost is one thing, but are we reducing costs just to try and help the government, or are we reducing costs for patient benefit, or are we reducing costs against patient benefit? And that's not always the same thing. They go on down, if we drop down here to the Department of Health and Human Services, down here, have published a document of best practices in pain management, which include interventional pain management techniques, and including, in addition to multitude of issues in managing chronic lower back pain, the COVID-19 pandemic and opioid crisis have affected chronic pain sufferers much more significantly than others, and this is, of course, very true. We can skip on down here. In a human trial, injected interdiscal bone marrow stem cells survived, proliferated, and differentiated. They secreted collagen and extracellular matrix despite the avascular interdiscal environment. Is also considered hypoxic. There's not much oxygen. It's acidotic and it's hypoglycemic. So it's nutrition poor, it's oxygen poor, and it's hostile because it's acidic. And yet mesenchymal stem cells can still survive and proliferate in there. We go on down and we see that multiple structures in the lower back have been described to be able to elicit specific pain patterns. However, structures proven to cause pain by precision diagnostic blocks include disc, facet joint, sacroiliac joint, and spinal nerves, whereas degenerative disc disease is diagnosed based on imaging. That is one of the interesting parts of this paper again. They actually give different injections depending on the patient's requirement. Patients were enrolled, they were given informed consent, they were checked, and they were offered conventional treatment or stem cell treatment when deemed necessary. One thing that I will say here, and I think is maybe a criticism of this paper, although I welcome your opinion, but the criticism I would have of this paper is that all patients were offered non-steroidal anti-inflammatory drugs at any time as needed under the treatment program. The issue I have with this is that non-steroidal anti-inflammatory drugs tend to have a direct opposing effect on stem cell or regenerative treatments, because the regenerative treatment is actually based on the body's ability to get the immune system involved, and these drugs actually inhibit the immune system. So I think that would have given them actually a worse outcome than if they had been strict and said that the stem cell group was not allowed to have NSAIDs. But I welcome your feedback on that as well, see if you agree or disagree. You'll also notice that people were given injections and opioids as required, and inclusion criteria: they had to be at least 18 years old, they had to have symptomatic moderate to severe low back pain with or without radicular pain which had lasted at least 6 months, field treatment already. This is very good. Exclusion criteria: patients with an abnormal neurological status, including Claudia Quina syndrome, immunosuppressed individuals with chronic infection or coagulopathy, and severe psychiatric disorder were included. Patients with active cancer, bone marrow disorders, immunosuppressive drugs if they could not be suspected for 4 weeks prior and 2 weeks after the procedure, and COVID infection. Now, this is actually we've just talked about with non-steroidal anti-inflammatory drugs, immunosuppressive drugs, I think they should be classified as immunosuppressive, but of course, when we talk medically, immunosuppressive, you start to think like chemotherapies and drugs for these rheumatic diseases, among other things. The intervention provided, now we could go into detail here, all patients had 54 mils collected with 6 mils of anticoagulant, so 60 mils in total, centrifuge down and then re-injected. We're going to go on down here to the outcomes and a little bit more to look at demographic. Both groups were similar in following areas, so age, gender, weight, height, duration of baseline pain scores and procedures previously. The BMI, however, on opioid use was higher in the control group, but more patients in the study group had a higher of fusion surgery or laminectomy. So there are some differences in the groups, and if we scroll a little bit further down, we can see that here. Remember that your p-value of 0.05 or less, or I should say less than 0.05 is significant, but anything high is non-significant. So the significant ones here, for example, the BMI, the average BMI was significantly different. Percent of patients on opioids, significantly different here, this one. The number of patients with previous spinal injection was almost the same in both groups, so you can see some things are different, some things aren't. Another thing that was different, average number of each condition in each patient. They have the different conditions here. So there was a difference. The study group actually had more problems, so you would expect them to have a worse outcome. We can then see the different groups here. Are there any other very interesting points down here? If we go right down to this one, annular tear, so we can see that 25% of the people who received stem cells had a prolapse, an annular tear. 5% of the control group had that. Now again, that would be something that should make the control group have a better outcome. But as we'll discover a little bit further down here, we can see that the scores versus time, blue is your stem cell group when looked at with the oswestry. Red is stem cell group looked at in terms of absolute pain scores. Now the VAS goes up to 10. You can see your oswestry goes right up here to 50. The interesting thing here is that your control group is the dotted line or the black line in both cases, and you can see that in both cases there's a statistically significant improvement, and it actually starts as early as 1 to 2 months after, and there's the 3-month timeline you can see just in the middle. So if you just look at the table, you'll see the 3-month, 6-month and 12-month. And another interesting finding here is that you have a very stable oswestry score or pain score afterwards, and there's a little bit of an increase in the pain overall when you look at the red line, but it is not much. If we look then a little bit further down here, we can see changes in pain scores. We can see minimal clinical difference, important difference here, and as they look at that, again, these are all statistically significant, so very interesting findings. Now, correlation of multiple variables. This is also a very interesting part of this paper. Binary logistic regression analysis adjusted for gender, age, BMI, duration of pain. Additional procedures showed that using an ODI score decreased by at least 10 points from baseline was independently associated with the study group at 12 months after procedure. Odds ratio without adjusting for gender, age, and so on was 24.0. 95% confidence interval is massive here, so that means it's very statistically significant. Additionally, independent was also shown that additional procedures did not influence the positive outcomes seen in the study group, so it doesn't seem to have mattered if they received other injections or even their NSAIDs, they still had good outcomes. This study shows a significantly improved function and pain relief in 2/3 of the study group, and achieved a minimum clinically important difference for oswestry at 12 months when compared to only 8% in the control group. That's a massive difference. Pain relief was also seen in 56 patients at 12 months and only 8% in the control group. The study group also showed reduced opioid usage. This is the first of its nature study looking at this, and actually what they haven't said here, control group actually had increased opioid usage, which is unfortunate. Here we have another table. It's worth looking at, the one in the middle here, figure 5. Correlation of ODI scores with the number of stem cells per milliliter, and you can see the scatter graph. It doesn't seem like there's a big difference because even these two people up at the right hand side here who've received the highest number of stem cells per milliliter, they didn't have a significantly better improvement than the people down in the middle of the graph at 4,000, 5,000, 6,000. So the dose didn't seem to matter. Part of that is because stem cells are self-proliferating. They can auto-renew, so if you put in a lot or even a few, there should be enough to get things started. We now have table 6, multivariate analysis. That's worth looking at if you want to see the difference between the groups, baseline and the outcome for people's pain. But finally, I wanted to just bring a highlight down here that their approach of multi-purported pain generators simultaneously is contrary to the traditional individual pain generator interventional management philosophy. And this is a very interesting topic because this is something that we actually adhere to in our clinic. We feel like patients often come in, and it would be wrong to talk about these patients and to treat them as a single point of pain when you get to lower back pain. Lower back pain is a complex and biomechanically complex issue where patients are burdening their spine in different ways and often will have multivariate reasons for their pain. So you don't have someone who just has pain from a prolapse. Often you have patients with prolapse, facet joint impingement, maybe nerve root impingement because of the facet and the prolapse working together. You might have nerve hypertrophy or edema around the nerve because of the irritation in the area. And so it seems to be, this paper would suggest, and I think in my clinical experience I would also agree with this, that a multivariate injection technique where you actually inject as much as you can around the area so that you're putting in peridiscal, you're putting into the laminar space, and you're maybe coming out and putting into the facet joints as well, to inject those areas and give essentially a nerve root block or a nerve root treatment at the same time as you treat around the disc and at the same time as you treat around the joint space, should give the best possible outcome. And that's something I recommend, that if you're doing this in your clinic or if you're a patient and you're getting it offered, this is definitely something to ask for, because it's technically not much more difficult. It just takes a little bit of extra time, but once you've done it, it's definitely of benefit to the patient. Finally, there are several limitations. First, it was not covered by third-party payers, so the people who enrolled in this study had to pay themselves for the procedure, and that means there may be a motivational bias toward better outcome. Secondly, the BMI was higher in the control group. That might worse outcomes. Additionally, this group had higher opioid use at baseline compared to the investigational group, although multivariate analysis showed that both factors did not impact outcomes. That's good, but could be argued. Based on MRI findings, the study group exhibited more severe spinal degeneration compared to the control group, so that would make it worse for them. They also had more annular tears, we talked about, which would make it worse for that group rather than the control group. Thirdly, multiple pain generators were injected simultaneously. Additional research needs to be performed to assess if good outcomes can be achieved by addressing fewer structures. And this is something that I think is worth studying again in the future, but as right now, these seem to be a good approach to just try and get as many stem cells in as many places as possible per injection. So their conclusion: autologous or patient's own bone marrow stem cell therapy represents an alternative to traditional treatments for lower back pain to provide pain relief by a multimodal MSC function of inflammation, anti-inflammatory, it's immunomodulatory, cell recruitment, and remodulating or regenerative potential. Stem cells have the potential to slow, halt, and in some cases even reverse this disease. A very interesting paper here, I hope you agree. Here's the conclusion section. I had forgotten to add that in. I can maybe edit that in post. And you can see here that stem cell therapy has the potential to slow or halt, in some cases even reverse the progression of degenerative disc and joint disease. Positive outcomes in this study population, which presented with severe spinal degeneration, were likely due in part to the combination of injecting high numbers of progenitor cells, addressing multiple pain generator sites at the same time. Stem cell therapy is a reasonable option to treat patients with lower back pain compared to conventional treatment. I think that's a very good point for us to round off. If you have any questions, I hope you'll leave them in the comment field. I'll try and answer them. I thought this was a really interesting paper. It's the first quality papers that we have on lower back pain, and it's very, very promising. So we've seen this in our clinical experience where we've been willing to offer patients an option, but we haven't had the good research to base it on. So now we're finally getting into an area where lower back pain also has some research backing up the fact that stem cells seem to work. I'll see you in the next video, and we'll maybe talk in more detail about another stem cell treatment option. We'll look at the lower back pain autologous versus allogenic stem cells. I think there's a very interesting paper on that, which we'll talk about in the next video. Have a lovely day, and I'll see you next time.